Okay, so this is our first topic, and it's our first topic in your first pathophysiology week, which is haematology and endocrine. So we're going to start with haematology. It's the only haematology. The remaining two are endocrine, you may have noticed. In this one, we're going to look at anemia, primarily iron deficiency anemia and megaloblastic anemias. And we're going to split it like we tend to split all of the pathophysiology. We split it into underpinning, which is the sort of main disease process going on, the pathogenesis of that disease. And then we follow that up with what I call the applied pathophysiology, which is about the signs and symptoms and how that underpinning pathophysiology then causes those signs and symptoms. And hopefully you'll find it really interesting. Anemia is defined as a deficiency in either erythrocytes, the red blood cells, or in the main component protein, which is hemoglobin. It leads to a reduced O2 carrying capability. Therefore, of course, there's going to be reduced delivery to the cells of the tissues. This reduced delivery, because most cellular respiration is aerobic, is going to mean that there's reduced ATP production in cells. Just to remind you, each erythrocyte has around 250 million hemoglobin metalloproteins. Each of those hemoglobin metalloproteins has 4 heme groups. Each heme group bears one Fe++ or Fe2+, one ion of iron, if you like. Those ions, that Fe++, each one will bind one molecule of oxygen. So therefore, we can say that each hemoglobin metalloprotein has the ability to bind 4 molecules of O2 at full capacity. In healthy erythrocytes, the higher the PO2, the greater the saturation of hemoglobin. In other words, more and more of those Fe++s are bound by oxygen. And this is governed by the oxygen dissociation curve. And a key characteristic of this is that, yes, it climbs steeply. And you can see here, we've got 1 O2 bound, 2 O2 bound. And gradually it goes up that slope until 3 O2 bound. With 4 O2 bound, then of course the plateau is going to form because you can't increase beyond that because there are only 4 heme groups in each metalloprotein. Let's start with iron deficiency anemia. And we can see where this is going really because we've already talked about iron. Each heme group has 1 iron, and there's 4 heme groups in each metalloprotein. Iron from the diet is absorbed by the enterocytes, primarily in the duodenum and the upper jejunum, for good reason that we'll talk about in a minute. And it's absorbed using specific transporters. The enterocytes monitor and regulate the amount of iron that they absorb from the lumen of the GI tract based on their own intracellular stores. So their own intracellular stores give them an indication of the total body iron levels and tell them whether we need to absorb that iron or whether it needs to pass through. To help with absorption, And this is why really most of this absorption happens in the upper small intestine, the duodenum. To aid with the absorption, we need gastric acid. This comes from the stomach. It lowers the pH in the duodenum. And this actually stops the Fe2 plus from becoming the insoluble form Fe3 plus. And therefore, it ensures really the absorption of the Fe2 plus. Then, of course, everything that's absorbed through the GI tract is transported off to the liver via the hepatic portal system for metabolism or storage. So when the iron, the Fe2 plus, gets to the liver, it's bound to transferrin. This is then released from the liver, from the hepatocytes, and transported via the blood to the marrow. Of course, it needs to go to the marrow because that's where we make our erythrocytes. Any excess iron is stored as ferritin, partly in the liver, but also in the spleen, in macrophages, because macrophages help with the breakdown of senescent erythrocytes, in enterocytes, because remember they have those intracellular stores that indicate what the levels are in the rest of the body, and also stored as ferritin in the form of myoglobin, which is a single heme in muscle. And the level in the blood is usually proportional to the total body ferritin. So those stores of iron indicate what the levels are in the circulation. And in most cases, this indicates total body iron. A low serum ferritin is only seen in an iron deficient state. And we all talk about iron being used in this way to transport oxygen, and that is one of its key functions, its main functions. But it's also used for other things. Iron is used in the electron transport chain. Do you remember the proton pumps? We talked about them being cytochromes. Cytochromes need iron for their synthesis. So you can see the impact here. Not only are we reducing oxygen carrying capability, which affects cellular respiration, but we are also potentially reducing our ability to synthesize those proton pumps in the electron transport chain. Iron is also used in the action of some enzymes, particularly those in the central nervous system. Because we have these large stores, and this is a common theme really in endocrine and hematological disorders, because we have large stores, any signs of deficiency tend to be very slow in onset. They are insidious. It's difficult to pick out. And here we go with our classic presentation, don't we? Of someone who comes in who says, oh, I'm feeling really tired. How long's it lasted? Well, I think it's been a few months. And this concept of this slow onset fatigue. So signs of deficiency are insidious or slow. Iron deficiency can be caused by any malabsorption. Obviously, it's all very well us eating lots of iron, but if we can't absorb it, then that's going to cause a deficiency. That malabsorption might be due to diseases such as celiac disease, Crohn's disease, Or H. pylori also has an impact because of this need for the gastric acid to prevent it becoming an insoluble form. Malabsorption can also be due to drugs. So again, it's about this gastric acid there in our example, because of course proton pump inhibitors reduce gastric acid. So therefore, we're not going to be able to prevent it becoming insoluble in the duodenum, and we're going to have malabsorption. Low dietary intake, of course, and or loss due to hemorrhage. Usually has to be either a persistent low-grade hemorrhage or a significant acute hemorrhage. In iron deficiency anemia, the erythrocytes that are released from the marrow tend to be very small. They're microcytic, small cytic cell. Because this deficiency of iron prevents hemoglobin synthesis. They're also very pale because iron turns red when combined with oxygen to form oxyhemoglobin. And it gives oxygenated blood, arterial blood, that bright red colour. That colour is going to be subdued or lost to a certain extent if there is a deficiency of iron to bind the oxygen. Which brings us on to megaloblastic anemia. Megaloblastic anemia is all about vitamin B12 or vitamin B9 deficiency. Both of these vitamins are vital for DNA synthesis during erythropoiesis, so during the formation of new erythrocytes in the bone marrow. The cell cycle, the replication of erythrocytes, is dependent upon B12 and B9. So if there is a lack of B12 and or B9, what we end up getting is these large, immature and dysfunctional erythrocytes. They're known as megaloblasts, and these form in the bone marrow before the erythrocytes are released. So as we said, because of the lack of this B12 or B9, which we need to synthesize the DNA for mitosis, for cell replication, the reticulocytes, so those erythrocyte precursors, end up becoming stuck in the growth stage of the cell cycle, the G2 growth stage. You see the green area there just before the blue M of mitosis, where the actual division happens. There's a lot of preparation in the cell cycle before you get to mitosis, and we'll talk more about that when we start talking about cancer, malignancy, and what happens in cells then in terms of that growth cycle. So these erythrocyte precursors, these reticulocytes, become stuck in the G2 growth stage of the cell cycle. They get stuck here and then they can't go through with mitosis. They've already replicated the organelles, everything that they need to make another cell apart from the DNA. The replication of the cytoplasm is not DNA dependent, so it is less impaired. And this is what gives them this large size. This is why they become megaloblasts, because they've reproduced all the organelles and the cytoplasm to make a new cell, but they can't go through to mitosis. So when we end up with these big fat bloody megaloblasts within the marrow, that can't synthesize DNA, so therefore they can't go through mitosis, what eventually happens to them is that they get destroyed. This is called intramedullary, as in the medulla of the bone marrow, intramedullary hemolysis. So they are destroyed in the bone marrow. So, of course, we're not going to release any new erythrocytes, or very few of them. So the circulating reticulocytes, remember erythrocytes when they're first released, are still pretty immature for the first 24 hours and carry on maturing as they're circulating. So the circulating reticulocytes and also, of course, the mature erythrocytes, the numbers will be reduced. Any that are circulating, the mature erythrocytes, so any of them that make it through, are going to be large. So they're, rather than microcytic, as in iron deficiency in this case, they are macrocytic. Those also tend to be very fragile and very prone to either rupturing, so hemolysis, or going into apoptosis. You remember the programmed cell death. And malabsorption, as we said, can be due to some drugs, to alcohol, or to chronic illness, in the case of B12 and B9 as well. When we talk about pernicious anemia, a lot of people talk about pernicious anemia in terms of overall megaloblastic anemias. But it's actually technically the impaired absorption of B12 due to a lack of intrinsic factor. So intrinsic factor is something that's secreted by the stomach, and it helps B12 to be absorbed. If we don't produce intrinsic factor, we can't absorb B12. We have technically correct pernicious anemia, but often it is used inaccurately for any B12 malabsorption. And again, we've got this issue of large stores. In this case, we're talking about large stores within the liver of B12. Remember, one of the functions of the liver is storage of lots of different vitamins. B12 is one of them. Because we have a large store there, it means that the onset again is very slow. It is insidious. And this can be over many years. And this is really where that word pernicious comes from. Pernicious means a slow, gradual onset. Okay, so let's do a little comparison in terms of what happens to our normal erythrocyte in those two conditions. So in iron deficiency, we have the inhibition of hemoglobin synthesis. Because of that reduced hemoglobin synthesis, we end up with these very small erythrocytes and a reduced ability to transport oxygen. So what we end up with is a few small microcytic and pale erythrocytes. In megaloblastic anemia, we have a deficiency of B12 and or B9. Because of this, we get this inhibition of DNA synthesis. So erythrocytes can't go through the normal cell cycle and can't replicate, can't proliferate. So we get an incomplete cell cycle, but we do get cytoplasmic replication, which gives us these large megaloblastic erythrocytes within the bone marrow. Many of those will go through intermedullary hemolysis, so they will be destroyed before they can be released into the circulation. Those that are released are macrocytic, they're large, we have few of them. They are hemoglobin rich, so it's unlike iron deficiency, we've got plenty of hemoglobin, but they are also very fragile. So remember, they are prone to rupture or to apoptosis. Other anemias are available. So we do have various other anemias. We're talking really here iron deficiency, anomalogaloblastic, B12, B9 deficiency, in terms of the more common ones. But there are other hemolytic and aplastic anemias. So in terms of aplastic anemia, we have congenital conditions like sickle cell or thalassemia. In sickle cell, as you probably know, the clues in the name, we end up with these flattened sickle-shaped erythrocytes. Another one is immune-mediated anemia, and often this ends up with hemolysis of our erythrocytes. The immune response ends up destroying erythrocytes, and this can happen in acute or chronic infections, or it can be an autoimmune condition. And other sort of extrinsic factors, such as large traumas like burns or lead poisoning. There is an issue with lead actually displacing the oxygen and the iron. So there are other. So our first one is pallor, which is pretty obvious, really. We've already said about these pale erythrocytes. So heme appears bright red when it's bound to oxygen. And this is because when oxygen is bound to the Fe++, this makes the heme change shape. And that subtle change in shape reflects the light differently. So that's why it appears bright red when oxygenated. So, as we said, in iron deficiency, erythrocytes pale because the lack of iron to bind the oxygen to the heme. In megaloblastic anemia, there are insufficient or dysfunctional erythrocytes carrying the oxyhemoglobin. So in one, we don't have the iron to bind oxygen. In the other, we don't have the erythrocytes to bind oxygen and give us that lovely red colour. So the capillaries and the venules, particularly in highly vascular areas, appear pale. And this is why we check the subtarsal conjunctiva, because that's a highly vascular area, it's easier to reach. The other thing that does contribute to pallor is if there is an acute or a really severe reduction in oxygen delivery, so we're going to have cellular hypoxia, this is going to stimulate the sympathetic nervous system via those peripheral chemoreceptors, remember glomus cells. If that happens, of course, the sympathetic nervous system causes peripheral vasoconstriction. So it wants to divert all the blood to the major organs to give them preferential perfusion. It vasoconstricts blood to the skin, to the periphery. And of course, if you get vasoconstrictions, it's the same as if you're cold and you're trying to conserve heat. If you get peripheral vasoconstriction, the skin appears pale. So our other sign or symptom that's relatively easy to understand is fatigue and weakness. Because of course we're not going to be able to make much ATP if we're not delivering oxygen to the cells for cellular respiration. Most cellular respiration is aerobic. So we're going to effectively have cellular hypoxia and reduced ATP synthesis. ATP is our source of energy for lots of cellular activity. So that's going to make us unable to perform those cellular activities if there is a deficit of ATP. Other issues, though, in terms of iron itself, in iron deficiency, iron is required for myoglobin. Myoglobin is our hemoglobin equivalent that we find in cardiomyocytes and skeletal myocytes. So both cardiomyocytes and skeletal myocytes are going to have a degree of cellular hypoxia too. In terms of cardiomyocytes, they're not going to perhaps have the same strength of contractility to maintain a good cardiac output, an optimum cardiac output. In terms of skeletal myocytes, then our muscles are not going to be as effective because they will be lacking in ATP. Iron is also required for the production, as we said before, of the cytochromes for the proton pumps in the electron transport chain. So in IDA, iron deficiency anemia, there is a potential that we certainly won't be able to increase the electron transport chains within the mitochondria. And those that we have may not be able to maintain their proton pumps. Another issue, remember oligodendrocytes? Oligodendrocytes, if you remember, are like the Schwann cells of the central nervous system. So they produce myelin that insulates around the axons within the central nervous system and also holds those axons together. And of course, this increases conduction speeds because we have saltatory conduction in myelinated axons. The thicker the myelin, the faster we have because that insulation is greater. So if iron is required for oligodendrocyte function and myelin synthesis in the central nervous system, we're potentially going to have some pretty slow conduction going on within the spine and within the brain. Iron is also required. We said before about iron is needed for various enzymes. The other thing it's required for is some of the central nervous system, in particular, neurotransmitters. So iron, if we have iron deficiency anemia, there may be issues with producing certain neurotransmitters. And there's a lot of research as to what neurotransmitters and according to what neurotransmitter, of course, the effects are going to be different because we have neurotransmitters that would bind and maybe be stimulatory or ones that would be inhibitory. So if we have a reduction in GABA, which is primarily causes IPSPs, then that's going to have a different effect than we have a problem with the production of glutamate, which is generally excitatory. And if you look through the research is very conflicting, very inconclusive. And really, other than knowing that iron is required for some neurotransmitters, we can reasonably theorize that yes, that is going to have an impact on transmission of action potentials within the central nervous system or systemically. I told you some of this is going to be a bit vague because the research is not necessarily there to say this is what happens or this is what doesn't happen. Sometimes nobody knows. Which brings us on to the cardiac effects. So we have tachycardia, palpitations, ejection murmur, awareness of rushing in ears, all cardiovascular effects. They tend to be seen in people with an acute anemia, or a severe untreated anemia rather than just your average person that walks in a bit tired all the time. And what has happened is that the sympathetic nervous system has been activated. And we talked about this before in terms of the pallor, and peripheral vasoconstriction contributes to pallor because of the sympathetic nervous system being activated. Sympathetic nervous system is activated because of reduced oxygen delivery to the tissues, so cellular hypoxia, and peripheral chemoreceptors. Remember, our glomus cells and the peripheral chemoreceptors monitor O2. It's also activated by any vasodilation which has been stimulated by tissue hypoxia. Tissues, endothelial cells, have various ways of protecting the tissues by releasing certain chemicals, we'll come on to some of them later, that stimulate vasodilation in that area to try and increase their perfusion. And that often has a knock-on effect by stimulating the sympathetic nervous system. Of course, good old sympathetic nervous system, we know what it does. It increases heart rate. It increases heart rate, so in this case that would be a good thing because, of course, it would increase cardiac output. And this would help to compensate for the tissue hypoxia. We would put more blood out. We would increase perfusion of our rather light on oxygen blood. It also, the sympathetic nervous system, you'll remember, also increases contractility. But we have a slight issue here in that the contractility increase may then be inhibited because, of course, the myocardium, the cardiomyocytes, are also getting reduced oxygen availability. They are also suffering from tissue hypoxia, and we're asking those cardiomyocytes to do more work by contracting harder to increase cardiac output. So contractility may be inhibited. If we inhibit contractility, remember, that will increase the amount of blood remaining in the chambers, in other words, end systolic volume. If we increase end systolic volume, remember, we reduce stroke volume. If we reduce stroke volume, that also will affect cardiac output. So in terms of our cardiac output equals stroke volume times heart rate. We've increased the heart rate. We may not manage to increase the stroke volume. Our other issue here is blood viscosity. Blood viscosity, because we don't have as many erythrocytes. If you remember, we talked about hematocrit and all the rest of it when we talked a little bit about peripheral resistance in physiology. So if we have fewer erythrocytes, that's going to reduce peripheral resistance. If it reduces peripheral resistance, then even if we increase cardiac output a little bit, it's going to counteract the effect on blood pressure. So we don't necessarily get an increase in blood pressure. Anemia is strongly linked, particularly in severe untreated cases, with left-sided heart failure. Patients may present actually with left-sided heart failure, and you find that they have anemia. Although there's a bit of a chicken and egg situation here. So, okay, what happens is, of course, we've got a hypoxic myocardium, we're asking it to beat harder and all the rest of it, so you end up getting a left ventricular hypertrophy. Often when you get, we'll talk about this when we talk about heart failure again, but when you get hypertrophy, ultimately, unless you can increase the perfusion to those cardiomyocytes, they will eventually go into apoptosis. So they will enlarge because of the extra work we're asking them to do, but if perfusion doesn't increase, then they will go into apoptosis. They will give up and die and say, well, that's all very well. You're asking me to do extra work. You're not giving me extra blood. So that's it. I'm off. And they would go into apoptosis, which then gives us heart failure. You then lose the ability to increase contractility because your contractility is disabled, if you like, by dead or dying cardiomyocytes. And this is the chicken and egg thing. And there are various mechanisms that cause this. If you're interested in it, please feel free to go off and read up on it. But there are various mechanisms where left ventricular failure also causes anemia. And approximately a third of left ventricular failure patients will go on to develop anemia. So anemia can cause left ventricular failure and it can be caused by left ventricular failure. So there's a real interaction between the two going on there. So dyspnea on exertion then. Now this tends to happen in more acute anemias. Because if you have, and this is a common mechanism really in lots of different systems, if you have a chronic, mild, low-level condition over a period of time, there are quite a few compensations that the body can kick in to try and compensate for that. So you get this concept of compensation. In chronic anemia, the vital capacity of the lungs increases to try and compensate for this reduced ability to carry around the oxygen. And this is a bit like athletes, because if you increase the tissue demands by lots of exercise, then the pulmonary system will increase its functionality, if you like, its vital capacity, to try and deliver the levels of oxygen that you need. So, okay, respiratory rate and depth will be stimulated, so it will be increased. Remember, the peripheral or the central chemoreceptors all report to the dorsal respiratory group, which communicates with the ventral respiratory group to increase rate and depth. In this case, we're talking about peripheral chemoreceptors because we're talking about oxygen. And we're talking about glomus cells within those peripheral chemoreceptors, which are in the aortic arch, aortic bodies, in the carotid sinuses, they are the carotid bodies. So those are our peripheral chemoreceptors that monitor for hypoxia. So if it's significantly reduced in terms of delivery, the chemoreceptors, not only will they increase rate and depth, they will activate the sympathetic nervous system. In addition to this, and this is what we were saying about the myocardium, there may be pulmonary congestion, pulmonary edema, because if you increase heart rate, remember we said you increase the heart rate to try and increase cardiac output. This is the sympathetic nervous system doing this. If you increase heart rate, you reduce the filling time for the ventricles. So you are going to reduce end diastolic volume. Now, normally what would happen, of course, the sympathetic nervous system also increases contractility, which then reduces end systolic volume to compensate. So there is no knock-on effect, no reduction in stroke volume. from that lack of end diastolic volume. But of course, the problem here is we have our cardiomyocytes that aren't necessarily receiving enough oxygen, so there may actually be reduced contractility. And this is where we're starting to get into the realms of heart failure. So when you get a left-sided heart failure, you get a backward failure to the pulmonary system. If you have a picture of the heart in your mind, of course, we're cardiac output from the left side is going to the systemic circulation, but we're receiving blood in from pulmonary circulation. If you can't move it out to the systemic circulation, you get backward failure into the pulmonary circulation. And we'll talk about this again in when we talk about heart failure. When you get this backward failure, you get congestion of the pulmonary capillaries. And if you remember, a lot of those around the alveoli, they become engorged with blood. When they become engorged with blood, it increases their hydrostatic pressure. If you increase the hydrostatic pressure, you push, transudate, you push fluid out of those capillaries into the interstitial area, but also potentially into the alveoli. So you end up getting this effusion into the alveoli of transudate. That's going to reduce gaseous exchange and cause even more problems. So you're not going to be able to transfer oxygen across the respiratory membrane or carbon dioxide out across the respiratory membrane. So you get this degree of pulmonary edema. This congestion of those capillaries also activates something called J receptors. These J receptors in the lungs are around the alveoli, around the alveolar capillaries, and they monitor engorgement of the vessels and an increase in interstitial fluid. And this is a fairly recent discovery. These are thought to stimulate this perception in the higher centers and the cortex of being short of breath. That sensation that someone may not have necessarily in increased respiratory rate or depth, but they feel short of breath. It's that perception of shortness of breath has been attributed to these J receptors. And we'll come back again when we talk about the pleural effusion. Okay. Another symptom, dizziness, poor concentration, insomnia, leg cramps. Obviously, we're talking about neurological issues here. And as we've said, tissue hypoxia is going to be fairly systemic. So it can also occur in the central nervous system and in skeletal muscle. Plus, if we've got iron deficiency, of course, remember iron had a key function in terms of the oligodendrocytes, so myelination within the central nervous system, and the production of neurotransmitters. So we have potential neurological effects due to iron deficiency as well. So a few more specific symptoms then, specific to conditions, just very briefly. So in iron deficiency, you will often see listed things like koilonychia, so spoon-shaped nails, glossitis, which is a sore tongue, and this is down to the loss of the little papillae that stick up from the tongue. Incidentally, it also happens if you give up smoking. That's why you get a sore tongue when you give up smoking, apparently. Angular stomatitis, yeah, from your OSCEs and your physical assessors, no angular stomatitis. Yes, and I've even given you a picture there just in case. Also known as cheilitis and pica. Now, pica, anyone? Yeah, pica. Pica is eating odd things. And this is what some pregnant women apparently do. They start eating chalk or odd things like that. And yeah, bizarre symptom. And as you can imagine, knowing the mechanism to these, the mechanisms really aren't known. And this is often the case because these aren't life-threatening conditions. And in terms of koilonychia, it's not even thought to be a particularly reliable sign of anemia. So no one's really researched them because they're not that important. But the theory, of course, is that it's related to the dysfunction of protein synthesis. In B12 deficiency, there are some additional neurological disorders. So things like paresthesia, loss of sensation, sensory loss, clumsiness, so loss of motor control or clumsy motor control, and mental dysfunction. And this is thought to be due to neuropathy. Neuropathy is a generic term, it just means disease of the nerves. But it's thought to be due to demyelination. And this is often the case. You get this situation where you get a correlation. So you will see that, yes, in people with B12 deficiency, there is often demyelination. That gives you the correlation. It doesn't tell you what's causing it. It doesn't give you cause and effect. So you don't know the mechanism. All you know is there is a correlation. Strangely, in Maine, in Canada, there's a correlation between divorce rates and eating margarine. So correlations are never really demonstrate cause and effect because that, as you can see from the example there, is a bit daft. So the mechanism isn't known. The bench research hasn't been done on this, but it's thought to be due to demyelination. In hemolysis, so hemolysis is about breakdown of the erythrocytes, lysis of the erythrocytes. This is going to release heme, and this gives us jaundice. It gives us a darkening of the urine, or in some cases red urine, and potentially bruising. So when erythrocytes are destroyed, of course, the heme is released. The heme, how we normally deal with it, it gets broken down into bilirubin. In the first instance, in unconjugated, and then it's conjugated by the liver, by the hepatocytes, for excretion. If there's large amounts of breakdown, there's going to be large amounts of bilirubin that the liver can't cope with, excretion pathways can't cope with. So we get a build-up of bilirubin, and bilirubin stains the tissues yellow. It's also what gives urine its normal colour. Bilirubin is metabolized to urobilinogen normally, and this gives us that normal straw colour of urine. Obviously, if there's large amounts being metabolized to urobilinogen, the urine is going to get darker and darker and darker. Okay, so that's the end of anemia. Just a quick reminder, hopefully you've picked this up from the intro video, but okay, there is a handout that goes with all of these videos that is basically the video in handout form. So it exactly reflects the content of the video. For those that like text rather than video, or those that want to use text alongside the video. So there is an anemia handout in PDF form for you to access. Also, time to start making your own notes and diagrams. And after every single topic, every week, you need to learn that topic material. So we're going back to the same techniques you used in physiology to try and learn this as you move through. including the teaching of others or working with a study buddy. And as this is your first Patho week, it's probably about time you started thinking about who can I work with. And bear in mind, of course, we've all got used to doing this online now, so there's no excuses. You could work with anyone in any part of the country or even out of the country by working with them online, and use a study buddy to teach each other. If you find that this is any reference to physiology is all a bit of a mystery, you need to go back to your notes and you need to refresh your memory, because we really are going to very quickly build on physiology with this module. Key thing, don't delay. Just like physiology, we are going to move on at a relatively fast pace, so you need to get everything under your belt before we move on. There is a reason why clinical reasoning is a module on its own. You don't do two modules at one time. It's because it is quite complex, because there are two sides to it. So please don't underestimate this module in terms of workload. Otherwise you're going to find yourself a bit stuck. There are, for this week's session, there are two more videos. There is diabetes and there is thyroid disorder. So that will then complete our hematology and endocrine pathophysiology week with any other related handouts or quizzes.